Okay, next we're going to talk about preventing cardiovascular complications. First of all, for orthostatic hypotension, this one is overlooked a lot, but if your patient is immobile for a long time, they're going to have difficulty with orthostatic hypotension when they start trying to get out of bed. So we want your patient to change position as much as possible. Walk if they can, stand if they can't walk, sit if they can't stand. We want to keep them hydrated. We want them to avoid the Valsalva maneuver. If they're not able to get up, move out of bed, then we can teach some isometric exercises and some bed exercises to improve blood flow from the lower extremities, and that helps maintain the autonomic nervous system. If a patient is having orthostatic hypotension, TED hose or compression stockings of some type placed before they get out of bed can help. They compress and help promote venous return so that they have less of that, all the blood falling to their feet and passing out thing going on. Preventing DVT and PE. Again, TED hose or anti-embolic stockings of some sort. SCDs, sequential compression devices. Also, some people have called them life-saving leg squeezers. They help promote venous return. There is one that's sometimes used, it's called a plexipulse. It wraps just around the feet, and rather than a slow inflation to promote venous return, it has a quick inflation, so it kind of punches the venous plexus to mimic walking better. That can also help. We want to teach our patient to avoid crossing their legs. We don't want to put tight clothes around their waist or legs. Avoid sitting for long periods of time. Avoid massaging legs, because if there's a DVT there, we don't want to dislodge it. And when you're positioning your patient for comfort, we don't want to put a pillow right under their knees. Okay, if we place a pillow, we want it kind of long ways under the calf, rather than having a bend at the knee to promote more stasis there. We want plenty of fluid intake. We want that patient getting adequate fluid. Obviously, we may have patients who have to restrict fluids for other reasons, but we want them getting adequate fluid to prevent DVT. Patients who are immobile frequently are placed on medications like a low molecular weight heparin to help prevent DVT. Pulmonary embolus. To prevent pulmonary embolus, do not massage. We don't massage legs. And if a DVT is suspected, we need to notify the provider and place that patient on bed rest until they've received an ultrasound. DVTs should be ruled out by ultrasound. If a patient shows symptoms of PE, what would that look like? They may, PEs are not always sudden. They can be sudden. The patient suddenly looks gray, says they're short of breath, complains of chest pain. They may even arrest. But often PEs are gradual and may even happen over several days if they're having a lot of small PEs. They may even happen over several days. So a patient that has a shortness of breath that's unusual for them, increased anxiety associated with that shortness of breath, those are things that we need to have a high index of suspicion. Pulmonary embolus is overlooked a lot. In an acute PE, they may not want to lie down, they're short of breath, they're very anxious, but you may see that their lips are purple. Okay, you're going to see maybe some cyanosis, but a lot of times we see that in the lips. Okay, next section is going to be on preventing musculoskeletal complications.